Okay, last, Connie Celum. Connie, we claim credit, trained at UCSF, moved north to Seattle, has been really, for her entire career, been interested in transmissional viruses, has done a ton of work with herpes viruses, but also HIV, and is going to kind of lead us through some of PEP and some of STIs, so batting cleanup.
Well, before I begin, I just want to acknowledge that Paul had a big hand in my career. When I was a third-year med student, seeing my first patient with Kaposi's, he brought a, I believe, hand-typed manuscript. There were typewriters in those days. But I also just want to thank the organizers for inviting me, and it means a lot to be in a course that's named for Scott Hammer, who is also a mentor, friend, and role model, and is greatly missed. So today I'm really going to focus on one aspect of management of STIs, which is prevention, and the new data that we and others have contributed in terms of understanding doxy-PEP. Here's my, my disclosures, our learning objectives, really which are, as I mentioned, focusing on data, much of which was presented at CROI, and many questions still to be answered, and some exciting data, not just about doxy-PEP, but about Bexsero for GC prevention. So I think you'd have to be kind of asleep for the last 5-6 years to not know that we're still, in spite of COVID and all the social distancing, seeing an ongoing epidemic of bacterial STIs. And these are the numbers from 2020, and I think one thing that started to really get people's attention is that for the first time in really a decade or more, that we're seeing congenital syphilis, which is really quite disturbing and has a lot of morbidity. So why is that? You know, we've been basically using the same tools for STI prevention for many years, which is talk to our clients. Some of us, you know, I'm skeptical that we, as a provider group, do a great job at that. I think that our language still is often, doesn't make people comfortable to disclose what they are doing or to ask questions. We do a lot of testing and we do a lot of treatment, and that clearly is not getting us out of this epidemic. The reason why the studies that I'm presenting to you are focusing on men who have sex with men and transgender women is because they bear the greatest burden of gonorrhea, chlamydia, and syphilis, as these data from CDC show. Why doxycycline? Well, there was some data that was presented almost now 5 years ago from a French group that suggested that doxycycline might be effective as post-exposure prophylaxis for STIs. And all the studies that I'm going to present were done to see, does it truly decrease the 3 most common bacterial STIs, gonorrhea, chlamydia, and syphilis, and what is the impact on antibiotic resistance? And the reason why doxy was chosen as opposed to any other antibiotic is due to its safety, tolerability, low expense, but really importantly is also biologic plausibility, that it has high efficacy against both chlamydia and syphilis with no cases of resistance ever reported in spite of widespread use, and that we know that gonorrhea already, about 20 to 25% in the US, 60% in Europe, close to 100% in parts of Africa. Gonorrhea has resistance to tetracycline, which is why we don't use it for treatment. So we're not going to, quote, ruin treatment of gonorrhea by using doxycycline for prevention. The first study that I mentioned was the IPRGAY study, which was a nested sub-study within the event-driven PrEP trial, that HIV PrEP trial that was done in France. It was smallish. It had 232 men who have sex with men, all of whom were on event-driven HIV PrEP. And they offered, they randomized to doxy-PEP or no PEP. And the way the participants were instructed was to take it ideally within 24 hours, no longer than 72 hours after condomless sex, and to not take more than 3 doses per week. And in that study, the average was really that they took about an average of 3.5 doses per month. They saw a 70% reduction in chlamydia, 63% reduction in syphilis, and no efficacy against gonorrhea in the context of high levels of tetracycline resistance. So people were interested, but by and large, this was not adopted because it was a single study. So my colleague, Dr. Annie Luckmeyer, and myself, and a great team of people in San Francisco and Seattle undertook what we called, not so creatively, the DoxyPEP study. And it was very similar to the one I just told you, except we did not put a cap on how much doxy could be taken. We told people not to take it more than daily. And we enrolled participants who were male sex at birth, who were either on HIV, living with HIV, or taking PrEP. We wanted to get more data for persons living with HIV for another status-neutral prevention approach, hopefully, who had at least one STI in the past year and had reported condomless sex with at least one male partner in the last 12 months. And then the trial, it was an open-label trial, similar to IPRGay. We did a 2-to-1 randomization because we wanted more data in the DoxyPEP arm, more tolerability, effectiveness data, and then STI testing was done every 3 months. And this was done at 2 HIV clinics in Seattle and San Francisco and 2 sexual health clinics. And to get to the punchline, and hopefully you've heard some of these data, they were first presented by my colleague and Dr. Luckmeyer at AIDS 2022, that shown on the left is the PrEP cohort. We designed the study to be powered to look, to have enough statistical power to look separately at those on PrEP versus those living with HIV. The blue is gonorrhea, the orange is chlamydia, syphilis is green, and then black is those who had 2 or more STIs. We designed the study expecting that we would see 10% incidence of STIs in the control arm, whereas we saw 30%. So this was a very sexually active population at high risk of getting STIs. And the difference in the DoxyPEP arm on the left and the no PEP arm on the right is almost identical between the 2 cohorts, translated to about a 2/3 reduction in both cohorts. And it was highly statistically significant. And about 10 months ago in May, our DSMB stopped us from further enrollments and told us that we had met our pre-specified efficacy threshold and that we should offer DoxyPEP to the control arm. I happened to be in New York on that day, and I was like, you've got to be kidding, because we didn't think people would take it well enough to have this kind of an effect. On this slide, this shows the same, basically the same data, but now broken down by pathogen and anatomic site. And the story here is just that, again, very similar results regardless of HIV status. We had very little urethral infection for gonorrhea and chlamydia. Most was so-called extragenital, and not very high numbers of syphilis. The median duration of follow-up at the time that the DSMB reviewed these data was 9 months. And again, we had expected to be continuing for another 1.5 years. And one question that's come up is, did it just prevent asymptomatic STIs, or did it also prevent symptomatic STIs? And the answer is it was significantly effective for both. I think it's important for people to know the context of these studies and the populations that were enrolled. The median number of sex partners was 9 at enrollment, and they reported an average of 5 sex acts per month. 90% of sex was condomless at enrollment. So this is not a situation where people started with high condom use and then decreased in the trial. And we looked in lots of different ways. We found no significant change in sexual behavior during follow-up, either compared to baseline in the DoxyPEP arm or compared to the no PEP arm. So there was no evidence of so-called risk compensation. Adherence is hard to measure in an event-driven trial with a short-acting drug like Doxy, but so we ended up having to use self-report. We still have hair samples in Monica Gandhi's lab that we look forward to getting data on, but Our primary measure is self-reported adherence at a quarterly interview, and 86% reported always or often using Doxypep after anal or vaginal sex. Similar rates actually with oral sex. The median number of doses per month was 4, and however, given the interquartile range, you can see that a quarter reported 10 or more doses per month. There's a trade-off. Because we prevented about 50% of gonorrhea, we also saw 50% less ceftriaxone use. So yes, you're using more doxy, but you're preventing more cephalosporin use. The big question that's been batted around a lot since we reported these data is, well, what's the harm part of the equation, particularly with respect to antimicrobial resistance? And I'll show you a little bit of these data. Some of this is still underway, but we're looking at GC, chlamydia, syphilis, mycoplasma genitalium, and then we're looking at so-called bystander bacteria, some of which have potential pathogenic potential, like Staph aureus, others not so much pathogenic potential, but could be carriers of resistance, like commensal Neisseria in the throat, and then the gut microbiome. And this was presented a couple weeks ago by our group at CROI. And basically, we had culture-positive gonorrhea to look at in I think it was about 40% of the GC cases, either at baseline or enrollment. And part of that is that you get less culture positivity. When you culture gonorrhea from the throat or rectum, it's much lower, something I don't think I knew in medical school. Or as an ID fellow. So that drops it down. And then also people who came to the study from Kaiser were often treated before they came in, and you have to do these cultures before treatment. So with all those caveats, the data that we do have suggests there was a non-statistically trend to more doxy resistance in the GC endpoints in the Doxypep arm, but this is not statistically significant and requires more data. We also reported at CROI that we saw a decrease, almost 30% in Staph aureus colonization. It was about 40% at baseline and went down about 30% in the Doxypep arm, and a slight, but again, barely at the threshold of significance among those who were colonized with Staph aureus at month 12. There was a slight increase in doxy resistance. We looked at commensal Neisseria. First of all, most people had it. Most of it was already resistant to tetracyclines, and it did not change during follow-up. I want to include this slide. This has not been presented or published, but I think it's really important to hear the voices of the participants, because I've heard a lot of voices from my colleagues who are also infectious disease specialists about concerns about antimicrobial resistance. But I think it's important, and we sort of learned this the hard way with HIV PrEP, is we focused so much on resistance. I can remember the early days, like from the Partners PrEP study, everyone was talking about resistance. People did not understand the meaning of a prevention intervention, people's lives. We did a purposive sampling of about 44 participants, all from the Doxypep arm from the 4 sites. We oversampled racial and ethnic minorities. And the themes, the overarching themes that have come out from this is that, first of all, people the men who were taking the Doxypep said that it gave them more sexual pleasure. It also gave them peace of mind. They didn't think it changed their sexual behavior, but just their mindset about it. And they felt empowered by it. And I think that's, a word as clinicians we don't use a lot. But I think when you're thinking about prevention and something that has to do with one's sexual health, it's an important construct. And they really felt like they were empowered in terms of their own health, but also they were doing something for their community, and that they were less likely to transmit. Some reported that they were aware of possible risks of antimicrobial resistance, but that was not and wouldn't be in the future a barrier to their use. Shifting gears now, a new study that hasn't been published yet but was presented at CROI, a very exciting study called DoxyVac. Again, Jean-Michel Molina was a PI, and it was a factorial design where they were looking at Doxypep plus minus Bexsero vaccine, Bexsero being a quadrivalent meningococcal vaccine that has proteins from the outer membrane that have very high homology with gonococcus. And they looked at doxy efficacy in terms of, they were designed it to look at chlamydia and syphilis. I'll show you. They also ended up showing efficacy against gonorrhea. And then for Bexsero, they looked at first episode of GC with the endpoint starting a month after the second dose of the vaccine. So they found about very, very similar point estimates to what we saw in the DoxyPep study, about a 90% reduction in time to first chlamydia, about 80% reduction in time to first syphilis infection. They found a 50% or 55% reduction, 51%, sorry, reduction in time to first gonorrhea, which is different than their prior study, EPERGAY. And they also, a little bit to their surprise, they found a reduction of about 45% or 35% in, need new glasses, in Mycoplasma genitalium. They found similar results as our study in terms of a very slight increase in more high-level resistance to tetracycline class and gonorrhea. They tried to culture chlamydia. Chlamydia is very hard to look at resistance unless you can culture it, and very few labs do that. They had 4 cultures and found no resistance, but none of these were from people in the DoxyPep arm. It gets to be really hard to ask those questions when you're seeing like a 90% or 80% efficacy. You don't have a lot of endpoints in the DoxyPep arm. They had very similar adherence. I should have said it in my presentation about DoxyPep, it was very similar to this, that the most reported that they took the DoxyPep within 24 hours after sex. And they took a similar number of pills as to what was seen in the DoxyPep study, 7 tablets, and had very high tolerability with very low discontinuation. And here are the data that caught a lot of people's attention. There's been lots of ecologic and observational data suggesting that Bexsero might prevent against gonorrhea from studies from actually almost 20 years ago in Cuba, then more recently in New Zealand, studies in the US. This is the first prospective data that suggests that the Bexsero vaccine reduced gonorrhea by 50%. So this would be great. This, if validated, I think this could provide a second type of STI prevention tool. The sobering news at CROI was that a similar trial was conducted by some of my colleagues in Kenya, presented by Janelle Stewart, and in collaboration with Elizabeth Bukuzi and Jared Baton, and they found a flat result in Kenyan women. They were from Kisumu in western Kenya. All the women were on HIV PrEP, so they are already presenting for some prevention intervention against HIV. They were not recruited based on whether or not they had an STI in the past year, so maybe that could have impacted adherence, but it was a flat result. There was a suggestion, but it's not statistically significant, and you have to be very cautious in over-interpreting data like this, but maybe there was a trend towards an effect with chlamydia. They had plenty of, they had more than they needed in terms of what they had powered the study for endpoints, so it wasn't an underpowered study. So there's a lot of discussion at CROI about, I do a lot of work in Africa in populations where 1 out of 3 women has chlamydia, 1 out of 10 has gonorrhea, and similar incidence rates. We need STI interventions for women in Africa and other parts of the world. So why did they have such a different result? Some have speculated maybe it's anatomy, maybe that chlamydia has, there's different endocervical columnar epithelium, maybe is different from rectal. Maybe it's PK levels, but I'll show you next that doesn't seem like that's likely. Maybe it's exposures and or when women used DoxyPep for regular versus casual partners. They have high levels, almost 100% tetracycline resistance in gonorrhea in Kisumu, or in Kenya, I should say. But we don't, as I said earlier, we don't think that chlamydia can, or certainly hasn't been documented to become resistant, so is that it? They recruited women who were in HIV PrEP programs. It was an open label design. Could that have influenced their adherence? They tried to provide adherence support with two-way SMS and lipstick containers so that women could take it when they traveled to have something discreet. They did their best to try to optimize adherence, in my opinion. These are the data that were also presented at CROI from Rich Hayland at the CDC that shows basically they did an elegant, simple, and important study to look at the mucosal concentrations of doxycycline and showed that for plasma, rectal, and cervical secretions, the concentrations achieved were way above what is needed to inhibit chlamydia, T. pallidum, and gonorrhea in vitro. And not only are they above it, they achieve those levels quickly within 4 to 6 hours. They persist out, and this was using 200 milligrams of doxy, which is what the studies had done. So it's sort of I think the conclusions from this is that, maybe in MSM we don't even need 200 milligrams. They are going to do ongoing studies with different dosing patterns. I think for women, if adherence is a factor, they're going to look at 2 fixed doses within a week. And it provides a model, I think, to now think about different regimens that might be tested. So where are we? We now have documented benefits in MSM and small numbers of transgender women who are included in these studies. It is an intervention that will work regardless of HIV status. Really high STI incidence. So one of the things that as we think about implementation is you really want to balance those who would most likely benefit versus achieve what at this point are relatively hypothetical concerns about antimicrobial resistance, granted with limited follow-up. We prevented each bacterial STI, gonorrhea, chlamydia, and syphilis in these 2 most recent studies. We estimated that you would need to treat 5 people to prevent 1 quarter with an STI. That's a pretty efficient prevention intervention. It's safe and well tolerated. It had very high acceptability as well as best we can tell, high adherence. And it did reduce exposure to ceftriaxone by 50%, which is, we want to preserve ceftriaxone for treatment of GC. What we need to learn more about, and we're fully committed to trying to do this, is to learn more about antimicrobial resistance through studies we're planning now about implementation outside of a clinical trial context. And these data, in my opinion, are important, but shouldn't stop us from moving into implementation. So where are we now with implementation? Our paper should be published within a few weeks. CDC guidance is being timed to accompany the publication, and I haven't seen it, so we'll see what it says. San Francisco took the initiative to develop their own guidance, and that's available through the website, and you can reach out to me if you want it. But they came out with recommendations in October. Last I heard, they have about 600 doxy-PEP users, and I'm hearing more and more about providers who are without CDC guidance are beginning to prescribe. But many providers, and we did interviews with providers, would feel much more comfortable once CDC guidance is coming. So there's been a lot of discussion, and we're trying to be agnostic and listen to the concerns about resistance, take them seriously, study them in a prospective way. And in my opinion, this is very similar to what Dr. Levinson presented about chest and breastfeeding of infants from mothers or lactating parents, I guess we should say, of infants. Is it should be shared decision making. I think that we should probably be doing this throughout our clinical practice. But we have knowns and unknowns, and we'll come back to that at the moment. But first, there's a question we want you to poll and see how much would you prescribe? And I'm sorry if this is too easy, but I like easy questions. So go ahead and answer if you were to prescribe it, how would you do it? I should have mentioned, the first question is not a totally stupid question, because they are in Canada going to look at doxy-prep versus doxy-pep. And there was a small study almost 15 years ago that looked at in 30 persons with the daily dosing, and it was effective. So, okay, is the poll going? Do I have to do something to do what? Sorry. Oh, you were listening. Thank you. Yes. Although, as I wanted you to see, that PK data from CDC, you know, the levels were really high for a while, and so I think it may end up that we don't need that much. But I'm not sure that we'll have another clinical trial to test 100 milligrams. And this is a question for which I'm curious. That I'm not sure we have a right answer yet, but just some of them are, the choices are easier than others. But would you, how would you, so this is not like based on guidelines, but from the evidence you've seen so far, who would you consider prescribing it to? Someone said in the water. Oh, that should be E. Oh, funny. STI-specific music too. Yeah, and I think that's a totally valid response, and we'll see what the CDC comes out. There's been discussion about should the eligibility be broadened so that it's not just MSM and trans women, as were included in the study, but cisgender men who have an STI in the past year. Should it be someone who perceives himself to be at risk? And I think these are some of the things that will get worked out. I think the data suggest, not just suggest, indicate that based on the Kenyan data that we should not be offering this to cis women. The clinical issues are pretty straightforward, and you know, again, I'm happy if people are already prescribing to share what we did in the study. We did do LFT monitoring at 12 months, found nothing. I think this can be quite simple. The hardest questions are really how much do you give, and I think that depends on someone's sexual activity. I think the more complicated questions are how to offer it, who to offer it to, and this is where I think language matters, and I think Mike Zag said earlier, offering and informing are pretty weak verbs, so I think we'll see what the CDC comes out. But I think that as a clinician, really, it's your job to try as best one can to have an open conversation and say, this is what we know, this is what we don't know, and what are your thoughts about it for you? And we have to, one of the areas that we dearly hope, is that we can do this through an equity lens. You know, it hurts, personally it hurts me every time I see the kind of data that Hyman showed in terms of the racial disparities with HIV PrEP. We don't want to duplicate this. There are issues with access to care for in rural and versus urban and different populations. So we're really going to try in our implementation studies to enroll enough to have more geographic diversity. Certainly San Francisco and Seattle are not representative of the U.S. So we'll work on that. We're going to also try to create floors in terms of the diversity and try even harder to recruit trans women. So there are a lot of questions like, should we change our STI screening frequency? The thought right now is probably not, but we will be working with math modelers. Will this have a public health impact? Will we get enough people on DoxyPep so it will have a public health impact? And we will also be working with modelers. So stay tuned. There's a lot of exciting and important work ahead. So last slide, I think, is just to say a starting point. I think I tend to like to keep things simple, not to use too many statistics when I talk to people, to say that it reduces, it's not 100% effective in eliminating the risk of bacterial STIs. that the studies were done in France, Seattle, San Francisco, and about a 2/3 reduction. And that we were surprised we didn't see more tolerability issues, maybe because they're taking it intermittently rather than daily. But they can't, I think you have to counsel people, especially in places where you actually get sun, as opposed to Seattle, about photosensitivity. Really counsel people about drinking water, because pill esophagitis, is, having experienced it, is very uncomfortable. And that there are rashes and fixed drug eruptions, but pretty rare. And that the unknowns really have to do with antimicrobial resistance. And I think we will learn a lot more as we have larger numbers of people on DoxyPEP if it is implemented. So I just want to end with a huge thanks. This was a challenging study. I think we started it in November 2019. So within 6 months, we had to pause for about 6 months due to COVID. Incredible team, incredible participants who are really motivated, and we thank our funders at NIAID. So thank you very much. Okay.
Rest yourself. Really super. Thank you very much. It's tough. I worry sometimes about STI talks because they can be by themselves kind of esoteric and go off in these many different pathogens, but this is really nice. It really brings it down to the PEP arena, which I think is incredibly important. I guess one question would be, you know, it took quite a while from the French observation to getting the trial even launched here. Were we slow in thinking about this, or just weren't?
I don't know that it was, people were thinking about it. There's always like almost inevitably a year or two built in with a gap for getting funding, and then we basically had to start the trial over after COVID, so we lost about a year, and then, so it was 2020, we were stopped October 2020 through May 2022. So in my experience,
not so bad.
It's not bad, but
I think there was quite a bit of
faster.
skepticism. I sensed it with the Molina study, the original one, right?
Yeah, so many people stood up at the mics and were concerned about, well,
Resistance.
honestly, there still is a lot of, I have to say provider, not a lot, but enough that it's bothersome to me, about, well, why don't they just use condoms? And one of my bacterial STI friends said that to me, and I was like, that ship has sailed, you know, yes. You know.
Well, in the early epidemic, one of our senators from California said, why don't they just stop having sex? Which,
that reminds me of a
You can do
conversation
that,
with
but-
my father.
yeah. Okay, Connie.
So just building on that comment, that was actually a comment from Bill Gates at a CROI symposium, or at CROI, the year he was one of the featured opening session people. He said, why don't you just use condoms? So anyway, my question actually, it's more out of curiosity than anything, but knowing your past work, I've heard very little talk about herpes virus infections in any of these PrEP and STI talks. So what's happening with all of these studies and herpes virus infections? That used to be the big scare for STIs before HIV came along. Everybody was concerned, oh my God, I'm going to get herpes instead of HIV. But now it's hardly ever mentioned at all.
Thank you, Connie, for that question. We have bank sero, and we will look at herpes seroincidence. That motion of taking a knife out of my heart took about 10 years to realize it.
And just for anyone to remember, what we know about herpes is probably from Dr. Celum.
A lot of people, but thank you. Unfortunately, we don't have an effective intervention except for antivirals, which in a study done long ago in HSV serodifferent couples who are both HIV uninfected had a 50% reduction, but it's never taken off really in that regard for uninfected persons of a partner with herpes to take it. Herpes remains a real challenge. There are people still working on vaccines. It's been a challenging, very challenging field, almost as challenging as HIV vaccines. So I think it's still important that epi data continue to accrue, suggesting that herpes increases the risk of HIV acquisition by about 2 to 3-fold, so we shouldn't leave it behind.
So, thank you. Should Doxy be included in post-rape treatment kits? And this is obviously a big issue, especially in gender-based violence issues in Africa.
I need to think about it. There's probably little downside. We certainly treat with ceftriaxone and other things for gonorrhea. Yeah, are you saying, is that your question then? Was this your question? Yeah, I think the reason why azithro is in post-rape is because of, for long times, we treated chlamydia also with a single dose of azithro, and it was this concern, I think, again, maybe a bit paternalistic, that people wouldn't take several days of doxy. There are studies that are starting to see for treatment whether you could get away with 3 days instead of 7. But let me mull that one over. And
come back next
question.
year. Question about mycoplasma for people that were became infected with mycoplasma on doxy pep. Should they be treated? Were they treated?
This was retrospective testing. They banked, I found out from the, John Michel that they had a multiplex assay, so they were just doing it and then without, they haven't analyzed it based on the proportion who are symptomatic. A small proportion relatively of Mycoplasma genitalium is symptomatic. It's a very controversial area in the field, so I think we need to see, see more data before we can know that.
Great. We've had quite a day. I have some final slides. I want to thank Connie and maybe by extension all of the speakers today for a great job, and Elaine for co-moderating. So before I show my final slides, thank you.
Thank you.